Welcome back, my friends, to another episode of the ASAP Pathway Podcast. I'm your host today, Dr. Stacy, and I'm just really looking forward to the conversation we're about ready to have. Today, our guest is Dr. Bill Harrell. Hi, Bill.
Hi, how's everybody doing? From
Oh,
the
I,
South.
I
Hello.
love it. Hi, y'all. I love it. I love it. I've known you for we've crossed over in our community for years, and I've just so excited to see the things that you're doing in the community to spread awareness and educate the world on this much needed topic. And I would love to introduce you, if you don't mind, if I take just a few minutes,
That's fine.
introduce you to those listening. Dr. Harrell graduated from the University of Alabama School of Dentistry in Birmingham, Alabama in 1975, completed his orthodontic residency at the University of Pennsylvania School of Dental Medicine in 1977. He is in private orthodontic practice in Alexander City, Alabama, and Auburn. Oh, how do I say this? Opelika?
Opelika. That's kind of, yeah,
I like
weird.
that word,
Yeah.
Opelika, Alabama. He's board certified orthodontist in 1989. He's also certified in dental sleep medicine. He worked with the late TMJ pioneers, Dr. it's Farah, right? You pronounce
Farrah. Yep.
Farah, even
Farrah.
though it's spelled Farrar. Dr.
hmm
Bill Farah and Dr. Bill McCarty in Montgomery, Alabama, in the area of TMJ disorders.
hmm
He served as the vice president and president of the Alabama Association of Orthodontists as the secretary treasury, um,
hmm
vice president and president of the Ninth District Dental Society of Alabama's Dental Association. He also served on various committees on the American Association of Orthodontists. He is the first orthodontic private practice in Alabama to have cone beam and the first in the USA to combine both cone beam, CBCT, and 3D facial imaging in the early 2005 era.
Right.
His practice focuses on airway-centered orthodontic diagnosis and treatment and TMJ disorders. He is also the chairperson of the RAD Cone Beam CT Standards Committee for setting standards for the insurance industry for reimbursement. He is presently writing and the lead editor of a textbook that's launching in end of this year, hopefully, maybe 2026.
Yep.
Fingers crossed. Sleep, craniofacial form, and airway function disorders. Interdisciplinary approach for assessment, diagnosis, management, and prevention, which is what this whole movement is
Yep.
about. And I'm so
Yep.
glad that you're launching this book and you have some big hitters. Do you want to mention who's writing this book with you?
Yeah, be glad to. One of my co-editors is David Gazal. He's a pediatric pulmonologist and the dean of the medical school at Marshall University, Joan Edwards Medical School. Now, David and his wife both are the most prolific authors now in the world on sleep apnea and sleep
Yes, they
disordered
are.
breathing, especially in children. My other co-editor is David McIntosh. Many of you have heard of him. He's a pediatric ENT in Australia, and we'll talk a little bit more about him too. But I have a number of, it's heavily weighted toward medical. When I started thinking about this book, I said, I don't want another dental book out there because medical doctors aren't going to want to read it. You want to kind of make it heavily toward the medical side, and because that's where the literature is. Unfortunately, in dentistry and even orthodontics, we point to, well, where is the evidence? Where is the evidence? Where are the articles? Well, they're not in our literature. They're in the medical literature.
Amen. I keep saying that, Bill. Bill, every time
Yep.
you and I talk, it's frustrating because I keep, we hit these walls of,
Yep.
well, show me the literature. And it's like
Yep.
it's all over the
It's
medical
all over, and you kind of got to get out of our little
bubble
bubble, so to speak,
or
and look
silo.
further. So that's kind of why I did this. One of my co-editors or co-authors is Jerry Simmons. He's a triple board certified in neurology, epilepsy, and sleep medicine. He's from in Houston, Texas. Uh, and Steve Carstensen, who's a dental, a sleep dentist in Seattle, Washington, but also the other medical side, Stanley Liu, who was at Stanford, took over Dr. Gimino's position at Stanford, who Dr. Gimino was the one that started all this stuff. And
Right.
I got to know Dr. Gimino and Dr. Dement and actually Dr. Powell and Riley out at Stanford a long time ago. So that's kind of where some of my stuff came from. And then so Stanley Liu is now at Nova,
Yes.
and uh, a number of other. Risa Movahead is doing a chapter on oral surgery, and uh, there's a lot of them out. There's a lot. It's heavily weighted toward the medical side, and I'll probably think about them as I go through this.
Yeah,
But
you've got some big hitters. You've got some
we got
big,
some big hitters. We actually got over 30 something co-authors, and that's kind of the challenge of
right.
getting this book out. Is it's not just one or two authors that are trying to put this thing together. I'm chasing cats all the time, trying to get this, that, and the other. Uma Katwa is a pediatrician at Harvard.
Yes.
He's doing a chapter. Uh, and others. And so we have a lot of heavy hitters that are giving. Two cardiologists, Andrew Maxwell and Dr. Malik, are cardiologists that are giving their side. So we got neurology, we got cardiology, we got malfunctional therapy. Nicole Goldfarb and Sharon Moore are doing a lot with that, and some others. So we got a lot of different. It cuts across all this interdisciplinary management, and that's the key to the whole thing. Is it's not just a one. It's not just one thing. It's not just all about expansion. It's not all about mandibular advancement. It's not all about it's all about every. It's a lot of things, and you got to kind of put your mind. Everybody's looking for that. What is the one thing? What's the
That's
one
right.
thing? It's
You know
like in
what?
that movie. What is it? The cowboy movie where uh, anyway they talk about what's the one thing of life. Well, it's not. It's multiple things.
And I
It's a
think
big
that
onion with a lot of layers.
when we all start, it is. It's an onion with a lot of layers. And
Yep.
when, when I started this journey, gosh, I mean, I started in adult dental sleep medicine,
Yep.
and even in the adult dental sleep medicine world, I go to a lot of events and it's all about, well, what advancement device are you using? You know,
Mm-hmm.
and in the pediatric dental sleep medicine, craniofacial growth, well, what's your favorite expander?
Mm-hmm.
It's really, you got to look at the whole person. It's not, yes, we do want to make a tube, the airway, less
Yep.
collapsible. And sometimes it's removing anatomic obstacles to that.
Right.
You've
Right.
got neurology, physiology, you've got gut health, you've
Mm-hmm.
got
Definitely.
nasal breathing patency, you
Yep.
have autonomic nervous system influences. This is multifaceted. And this is why
Absolutely.
your book is so important.
Yep.
Uh, and on one hand too, when I talk to people, Bill, it's like if it's just a matter of just doing one thing, they're like, okay, I'm in. Let me just do it. I want to blow it up and fix everybody.
Yep.
And
Yep.
especially dentists, we are really good at the mechanical side of things. Give me something
Mm-hmm.
in my hands,
Right.
let's fix it.
Yep.
And but I want people to understand we are a piece of the puzzle and we are needed, but we're not
Mm-hmm.
the only piece. So do not put the whole onus on your shoulders that once you do expansion or craniofacial development or you put a mandibular advancement device to stabilize an airway, it's needed, but you're not done.
Yep.
You have to collaborate and you have to
Yep.
work with your medical colleagues because we have to all
Exactly.
do this together. So I want to get back your journey. So here you are, you're an orthodontist. You know, I'm looking at what you have seen over the years. I mean, you graduated in 77, right?
Right. Right.
So you've seen some things. And
Yep.
what was it, first of all, how soon in your journey or late in your journey did you start questioning the status quo? And what was it that made you challenge the status quo of what?
Yeah. Interesting. Yeah. I graduated in 1977 and actually set up my practice here in Alabama in 1977. And, we were we had a 2-year program, so it's kind of like we'll talk a little bit about the educational system and how it's kind of done, and that doesn't lend itself as much to looking at airway, but we'll talk about that. But of course, I was practicing normally, and then there was I mean, traditionally, I guess, during those periods of time, in about 1982, Harwell came out with those monkey studies
Yeah.
where they plugged up their noses and they created all these malocclusions in a set of animals that don't get retrognathic mandible normally. They don't get crooked teeth. They don't get narrow arches. They don't get, and you started looking at that going, maybe all this stuff we've been talking about, hey, it's all genetic and we can't alter it. Uh, Maybe the genetics sets the stage, but maybe function. And Melvin Moss, we studied Melvin Moss in the functional matrix back in the day, and it's all about functional spaces. And we kind of thought he was crazy, I guess, at the time. And then one of our instructors there at Penn we'd look at doing some functional appliances, and we thought that was crazy. I mean, we were like,
Right.
why are you putting these bionators and things? And we did those things, and we're kind of like, we want to get in there and put brackets on teeth and move stuff around. I mean, like, you said, we're trained mechanically. The
Yes.
dentist, or that's just the way we are. And that's what got me interested in orthodontics in the first place. But about when that happened, I started looking at things a little bit different in these patients. And I started looking at their narrowness of the arches and going, hmm, you know, where's the problem? Is it the bones of the teeth, or the teeth the real problem? And is our focus just going in there and making things pretty, making a pretty smile, making a pretty face so they win a beauty contest or something? But what about some of these other things that are going on? And there were some patients that we treated and we the traditional way, and they looked great, but they may have come in and looked like they hadn't slept in a while and things like that. So some of those things on their faces just kind of made me start looking at that. And then Jim McNamara, who was one of our major orthodontic the chairman at Michigan at the time, he did some studies. Linda Aronson actually came out with a study on children that had enlarged adenoids and tonsils. So all these things started coming out in the early to mid 80s, and we're reading all that, and I'm going, well, maybe airway, maybe the breathing pattern, uh, even though maybe the patients are growing up in the same household, and they go, well, their facial pattern is similar to their mother, their father, or something like that, but maybe the environment
Mhm. That's
has a
exactly
lot
genetics,
has a
right?
lot to do with that.
Right.
And so I started kind of questioning that. And then, I really, I guess when Jim McNamara started looking at things, he actually he took a year sabbatical to go over to visit with Rolf Frankel in East Germany. So this is East Germany.
Mm.
And he studied the, excuse me, the Frankel appliance. Let me get this thing off of here. Why this thing? Well, I'm trying to, okay, get that. That's my reminder to people like that. Sorry about that.
Don't worry.
Uh,
That's
but
called life.
McNamara went over and started looking at the Frankel appliance. Now, the Frankel appliance is really a wicked looking thing.
Yeah, it is. It looks a little medieval, but
It does. It really does. And of course, he went on to spend a year with Rolf Frankel, and they didn't have braces or anything there. They used the Frankel appliance, and they used it early. And they were treating airway way back then with this contraption. And basically, what it did, it had shelves on the outside that took the cheeks away. You look like a chipmunk when you put this thing in. And then the way it was designed on the inside was to control the tongue position and allow for proper tongue function. Um, And I kind of got on that bandwagon for a while. Um, and the ones I treated with that were amazing. The ones that wore it, but guess what? They had to wear it 20 something hours a day.
Yeah.
Uh, it didn't take long for me to have to back out of it because of patient, parents would come in and go, I don't want them to wear that crazy thing that Susie has. So anyway, but it kind of made a point in my mind that, maybe expanding this envelope and making room for the tongue and making room for proper function really has a role. So I started looking at those kind of things as far as palatal expansion, some uprighting and things like that. And one of the major chapters or a few chapters in the book that are going to be published, Dr. Karen Davidson, you probably
Yep.
know her or heard of her.
Yes.
Um, she talks about nasal resistance. And, when we look at this airway situation and we're looking at like even cone beam, we can talk about how I use that, but we're looking at we look at say, well, look how big we made the airway, especially in the pharyngeal area. I mean, even surgically or whatever, what are we looking at? We're looking at the pharyngeal airway. Well, guess what? That's that's just one part. That's the bottom part of the airway. Karen Davidson and I coined this term called the wine bottle theory. So think about a wine bottle just a minute. And let's make the base of it really big where we can put a lot of wine in. But where's the problem? Where's the resistance? The
Exactly.
resistance is up in the top.
Upstream.
It's
Upstream.
upstream. It's nasal.
Yeah.
And Christian Gimeno said, I've got a copy of his video uh, where he was interviewed, and he said, if you don't get the child to breathe through their nose properly, especially at night, you have not fixed their problem.
Correct.
Now, here's the kicker. Here's what dawned on me a long time ago. The maxilla is not really a separate bone. It's only a separate bone when the oral surgeon goes in there and cuts it away from the
Right.
nasal bone. So this whole complex, and Kevin Boyd talks about this. He's doing another chapter in there about that. But he talks about the nasal-respiratory complex, and it really is this whole region of the face from sinuses down, even into the area in the pharyngeal area. It's all about airway, and so it's the nasomaxillary complex. So when we go in there and start widening the maxilla, and I like the way you said, part of our treatment is to reduce collapsibility. It's not necessarily to make the airway
Bigger.
bigger, because
Correct.
this is the thing that Karen Davidson preaches. It doesn't matter how big you make the airway. If you've got areas in there that have a lot of resistance,
Yes.
you can, like the wine bottle, you can make the wine bottle base just as big as you want to make it.
Right.
And look how well we did that. We made the airway bigger. We looked at it with, echovision or some other things like that. But rhinomanometry, we use four-phase rhinomanometry a lot, and it measures airflow. It measures nasal resistance. And we don't talk about, we do a lot of lip service to, hey, we got to get child's breathing and things like that going. But we, we even in a cone beam CT, when I take a cone beam CT to look at these, and I take them pretty much routinely on everybody. If I want to see the whole picture, I've got to have some three-dimensional imaging. The 2D cephs and that kind of thing don't give you proper information. But I look at that airway and we model it out, and we model the pharyngeal airway. And my goal there is it's not to diagnose an airway issue necessarily. It's upright and awake. Okay.
Right.
Okay, I agree with that. That's what we got to do. I can't lay them down and put them to sleep. But just if the but if the airway is small, if it's tending to be small, then what's happening? I mean, it's a starting point. And so if it is small, then I say, well, you got a small airway. When you lay down, it's going to get, it's going to get worse. Hang on just a minute. Let me cut this thing off. I've been I'm sorry, my phone is doing all
Bill,
this.
you're just popular.
I know it. There's all this crazy stuff anyway. Sorry about that. But anyway, that's kind of the thing. So when Karen Davidson and I kind of got together and started talking about this, it just made sense that you really got to look at the nasal function and not just we take the cone beam and I'm looking at deviated septums. I'm looking at even the opening of the
Valves, yep, the
nostril,
nasal
the
valve.
nasal valve and the turbinates, and then back there the adenoids and the tonsils. Because a lot of studies have shown that one of the treatment for kids that have sleep disordered breathing is the top enlarged adenoids and tonsils. So we go in there and take those things out, and for a little while they can breathe a lot better because the
Yeah,
the stuff's out of there.
right.
But it's not long after that then it
Honeymoon
tends.
period. It's the honeymoon
Yeah,
period. Yeah.
it is, and it starts to deteriorate. And so we go, well, maybe the tonsils and adenoids, but they are part of the problem. They're enlarged areas that aren't supposed to be enlarged. And so, but the problem that you don't they don't look at is the narrowness of the arches.
Hmm.
And here's two things that I tell parents, or even when I do lectures, it's it's like trying to put a 4-bedroom house on a 2-bedroom foundation. You got 4-bedroom house worth of teeth. You got a 2-bedroom foundation that's developing. Where's the problem? Do we want to take the house and shrink it up? That's what we've done forever. Or do we want to make the foundation bigger? And when do we do that? Here's another. Uh, here's another one I use, which is maybe more pertinent. Uh, have a size 11 foot and you
Yeah.
try to put it in an 8 shoe.
I use that analogy a lot with parents. You gotta,
Yeah.
it's way
Is
too, your shoe's too small.
Yeah, yeah. And what have we been doing forever? We've been waiting, watchfully waiting these kids, going, we just let's wait till all the permanent teeth come in, get bad as it's gonna get. And what do we do? I mean, technically we've cut off all the toes and make them fit the shoe. I mean, that's what we do. I mean, it's that dramatic. But anyway, I mean, where's the problem? The problem's in the
Exactly.
foundation. It's in the shoe. Why don't we make the shoe bigger? Now, when can we do that? Well, you got to do it early. Here's another thing it's in the book that I talk about. It's like a child that's got club feet. When do they treat club feet? And I'm trying to get some. I want to get some information. Stanford Orthopedics is going to try to hopefully get me some pictures and things of this. But you take a child that's got club feet, they're born with club feet, they're working on them within the first few weeks
Yeah.
of life.
Yeah.
And the Mayo Clinic says the reason is because their feet are moldable at that time. They can put them in the Ponseti method, which is the casting, and they mold the feet. They overcorrect. They come back with corrective shoes. So by the time they're walking, they can walk and run and jump just like everybody else because now their feet are molded back to normal.
Well, Bill,
You,
it's like there's so many, and again, it's when do you identify a malocclusion
yeah,
and when do you address? So with clubbed feet, to them it's pretty obvious. We got a
yep,
problem.
yep,
Houston, we have a problem.
yep,
So you're going to start earlier because,
yep,
as Mariana Evans says, that's when they're nice and squishy and
yeah,
juicy. And
yeah,
the bone is juicy and squishy. And so
yeah,
you can move things easier. The
yeah,
big hesitation in the orthodontic community to get everyone to even agree on what is a real malocclusion, when is it a malocclusion,
yeah.
is lack of spacing of baby teeth considered a malocclusion? And it should be, it
It
is.
should be. Yep,
So that is the first identification of malocclusion. So
Yep.
you got to get a whole community of people even agreeing when there is a problem. Can we
Yep.
all agree on when is something identified as a problem? What's the diagnosis? Uh,
Yep.
where's the malocclusion being identified? At what age is a
At
malocclusion?
what age?
So
And
then,
yep.
and then not only can we agree on the malocclusion, then it's why intercept so early? And that's the big debate
Yep.
in orthodontics, and the mindset of some of, there's this, and you can find a paper to support anything you want to believe.
Yeah. Exactly.
You really can.
Yep. Yep.
So it comes down to what are we seeing even anecdotally within our practices? So you obviously shifted your mindset from traditional, let's wait till they're 12 and 13
Mhm.
and wait for, that what was considered the big event is braces,
Yep.
right? Braces is the
Yep.
big event. And it's like what's really backwards. The big event is the orthopedics. The
Yep.
life-threatening events are orthopedics.
Yep.
And, I also bring up, and I got this from Kevin Boyd too, years ago in my journey, like why would we don't wait to put glasses on a child
Yep.
done growing. We
Yeah.
don't wait to, even though they're going to have different size glasses throughout their life,
Right.
we're not
Yep.
going to wait. We're not going to wait for hearing aids for a child till their ears are kind of done growing because, they're going
Yep.
to have several sizes of,
Yep.
of hearing aids. Well, the reason we intervene early with those things is growth and development.
Hmm.
A child needs to hear,
Yep.
and it's all about cognitive development, executive function development.
Hmm.
And we do know with the Karen Bonnick study that children that snore, not just, this had nothing to do with any sleep apnea diagnosis or AHI.
Yep.
Thousands of children. I think it was 11,000.
Yeah. Yeah.
Um,
Remember that study?
yes, that at such a young age, it affects cognitive uh, deficits and behavior so much so that it's like, okay, we need to sound an alarm, kind of a zero tolerance of chronic snoring. Now, I'm not talking snoring for 2 weeks because your kid's nose is stuffy from
Right.
the cold. Yeah, you
Right.
you definitely want to clean it out and help, but okay, so your mind shift started. You saw the Harvard study with the
Mhm.
monkey that raised some like, wait a minute, this isn't just genetics, this is epigenetics, this is
Right.
environmental factors.
Right.
So then it's like we all have to do the first case, right? In a kid in our practice.
Yep.
So you come back with all this information, and I find it interesting. I'm very blessed that when I got out of dental school, my first associateship was with a dentist who was airway minded, who taught me a lot, really set the trajectory of my journey, really. But he had a TMJ, function minded background. And I find that a lot of people that get into the orthodontics, orthopedics, especially general dentists that maybe not have done it before, they kind of have this function TMJ craniofacial pain background first.
Yep.
And
Yep.
they start seeing, and it kind of, goes into this other trajectory of airway, sleep.
Yep.
And they kind of anecdotally were helping jaws and craniofacial pain. They were helping with just growth and development. And then they had this side effect of all these health improvements. So, what was it for you that you started seeing? You had to have, because what I'm hoping is that there are orthodontists listening, there are general dentists listening, or medical docs and the lay person listening right now that may not, they're just on the fence or they really don't want to do this at all. Their mindset. What did you see that made your mindset go, whoa, without all the plethora of literature yet?
Right. It's interesting when I worked with Bill Farah and Bill McCarty. Now, Bill Farah, he died in '85. I worked out of Montgomery from 1979 to 1985 with him. He's the one that described clicking, popping, locking the displaced disc and all that. People didn't even listen to him back in the 60s and 70s. He literally got thrown out of an ADA meeting, literally. His slides got thrown out, and they said, "Redneck, get back to Alabama. You don't know what you're talking about." Well, it wasn't too many years later till the orthogram came on the scene and they started injecting dye in the joint to see that, hey, this guy really knows what he's talking about. And then
Right.
McCarty, who was the oral surgeon, developed some of the original, open joint type surgeries for repositioning disc and things like that. So I got to sit in on surgery. If you really want to know about TMJ, you need to find you an oral surgeon that's still doing open joint.
Right.
Some
Yeah.
of these and go look at it because it'll change your whole focus, how squishy all that stuff is and how destructive the joints are. Arthroscopic's one thing, it's great. And I've sat in on that too. But that taught me, it is interesting. Michael Gelb and I talked about this at times when we meet because his father, Harold Gelb, was big in TMJ. And Harold Gelb and Mike and Bill Farrer were like big buddies. I mean, they were like tied at the hip on things. And Michael and I talk about it. We say, when we were doing those anterior repositioning splints, the Farrer splint, has a big lip on it to move the mandible forward to capture the disc. Guess what? We were opening up airways,
You were
and we
inadvertently.
didn't, we didn't know it. We were using anterior repositioning splints and opening airways, and we really didn't even realize it. But patients were getting more comfortable because of their TMJs being in a more normal position, but also their airways were opening up. And so that dawned on me, I don't know, a while back when we started, when Michael and I got to talking to each other about it. But it's just here, and here's part of the problem. I teach at UAB and I teach it in in the orthodontic department, great orthodontic department. And we're starting, and I'm bringing on the TMJ kind of part, and I'm bringing in the airway issues. But most programs, most orthodontic programs, everybody got to understand this about why it's like it is. Most orthodontic programs are 3 years now. They were two. I was two. Now there's 3 years. So within the 3 year period of time, you're expected to get your patients and treat them from start to finish because they don't want people to keep referring down the thing. So it does not lend itself to seeing a 6 year old or a
Right.
7 year old or an
Right.
8 year, unless they've got a big crossbite or something. It's just it's just not geared that way. So one of the things I brought on the scene is, hey, here I have a private practice and I've got patients here at 6 or 7. Now let's look at the progression of these cases. So we're so that's kind of where it comes from. The faculty within that university, you need somebody that at least starts showing these cases and the progression of that. Because otherwise, you're just not going to get it. You're just going to, all you're going to see are 12-year-old and further. And then the stage is set, and then you're kind of sunk.
Right.
Because there are times I get them too late. I don't have a choice. I don't have enough foundation unless we start doing a lot of surgery, which a lot of them aren't going to do. Then I'm kind of caught between a rock and a hard place. But if I do have to extract, I'm going to do it in such a way that I'm keeping it as wide as possible. Now, by the time I'm keeping it as wide as possible, I probably would have had room for the
Right.
teeth anyway.
I know. Then you're like, wait a second.
I know it. So I can't I can't count on my hands in the last probably 10 or 15, 20 years how many extraction cases I've done because I treat them early. I want to see them before 6. And we talk about the primary dentition, and ideally, that's when you need to look. Now, what does a malocclusion look like in the primary dentition? If you've got a big class 2 or something like that, I mean, man, that's you're having that's obvious, like the club feet.
Right. Right.
But if they're class 1, little bit of deep bite, and all the little pearls are all lined up straight like this. Everything looks good. So your mindset is you compare that to what our goal is in the permanent dentition to have all the teeth nice and pretty and straight. But guess what? That's a malocclusion.
That's a
When you don't
mallet.
have when you don't have a nickel, supposedly you need a nickel of space between all the teeth. I mean, it just makes common sense. It's just a physical law of nature. You don't have to prove it. You can't put two things in the real world. You can't put two objects in the same place at the same time.
Correct.
If your primary dentition is like this and everything's nicely lined up, look like little pearls, number one, without even an X-ray, you know good and well they're not going to have enough room. I mean, the permanent teeth
The permanent teeth are so much bigger.
so
So
much bigger. I mean, it's just obvious. Come on here, don't. It's not like where's the proof? Well, the
but
proof
to
is
the point of, so let's get to the orthodontists that are listening. It's like, yeah, but I have this paper that backs up that I don't need to go through multiple expansion processes. I am going to just wait and then I'll deal with it. Either one round of expansion at the
yeah,
end. Why do I need to, accept, or, I wait for growth spurts, which we do know that, there are growth spurts and you're going to get
yeah,
more sagittal corrections and things like that. But why do you say start so young at the sign of the malocclusion when you don't see the nickel-sized spacing between those
right,
baby teeth? What did you see in your practice when you actually started that made you go, yeah, you got to get to him before 6?
yeah. And I use a lot of E arches. Okay, I use powerful expanders a lot, but if and here's another thing that we orthodontists I think don't understand is do you expand a case that doesn't have a crossbite?
Right.
Because that's what we've been taught forever is when do we do expansion? When there's a unilateral or bilateral crossbite, maybe with a mandibular shift. That's obvious. And, that if you see them at 5, well, maybe not 5, but if you see them at 6 or 7, once the permanent molars have erupted, then you say, well, I have an anchor unit to hang on to that's a permanent tooth. So that's kind of the mindset is if we're going to treat a child with a crossbite, maybe we wait until the permanent 6-year molars
Yep,
erupt. So
that's
we
a
have a
really, yes.
so we have an anchor, a big anchor unit.
But let me ask you this, like most of the time when I've been expanding, the thing is too, they don't think that the sixes will follow. So when you are expanding, well, if you expand the primary dentition, the first molars aren't going to necessarily follow the expansion. But in my experience, most of the time it does.
It does. It
So
does.
that kind of I remember being told that by a few orthodontists, like, oh, well, you're expanding too early, and you're not the first molars aren't going to follow, and but I learned under Jay Gerber and some of these guys that have been around a long time, and they're like they follow.
They follow. There's interdental, there's the ligaments that are
Yes,
attached to all these things.
yes,
And
yeah.
people say to me, well, why? I mean, parents ask me, why are you going to widen the baby teeth? Does it affect the permanent teeth? Well, the permanent teeth grow within the roots of the baby teeth. You widen the baby teeth, the permanent teeth are
They're
going to kind of
going
follow
along for the ride.
a
Yeah.
different path, and that's going to influence the 6-year molars. Okay, if you if I could, what's my ideal that I'd love to see them at about 4 or 5 years of age when all the baby teeth have erupted, and I can put yes, I attach like E arches, spring loaded arches, just to up. I'm remodeling the dentoalveolar on a lot of these that are maybe they don't have cross bites, but they're narrow. And if you look at the intermolar distance between the primary molars, it should be around 28 or so millimeters just between the primary second molars. Now, if you go back to the 6-year molars, that should be up in the 35 or so range. And, you get a lot of, growth occurs, and you're going to get growth, but if okay, so you don't want to treat them at 5. Okay, all right, maybe let's at least look at them at 6 or 7, because now you can hang on. If you want to wait for the permanent teeth, you're letting growth occur abnormally is the
Yes.
problem.
Yes.
I mean, you're watchfully waiting this child. It goes back to the club feet. Okay, they got now, that, like you said, but that's obvious. You can see it. And this is kind of more hidden. It's a more hidden problem.
Not only hidden, but it's getting the community to agree on, is it really a malocclusion that kind of needs to be
Yeah.
addressed? And I mean, we all know it's not going to get better. So when you don't
No.
see spacing of baby teeth, just like the
Yep.
paper, the Vogue paper, where he talks about,
Yep.
let's, when you don't see the spacing, that is a malocclusion. And
Yep.
here's the big picture too. You need to ask the question. I mean, we could sit here and talk about the mechanics and what we use off
Right.
the rock.
Right.
It's why is it like that?
Why is it like that?
Why is
Exactly.
it like that? And trying to collaborate, get to the root of, I hate using the word root of the problem because it's very multifaceted.
Yeah.
It's
Yep.
the chicken or the egg, even like some people, what
Yep.
came first, the poor breathing, then the
Right.
arches, or the arches and the poor breathing. And it's,
Right.
yes, it's all of it. It's all
It's
of
all of it. And we're trying to solve an academic question, and we need to look at the patient.
it.
And yeah, orthodontists are not going, we traditionally are not going to see, 4 or 5 year olds. I mean, as young as like Kevin Boyd does. I mean, he sees them at birth almost,
Oh, yes, yes.
and if you can do that, great. I can't manage that young, but 4, 5, 6, I do. I'm starting to see them a lot earlier, obviously. Now, the American Association of Orthodontists said that, all children around 7 years of age should see an orthodontist. I think it should be before 6.
Yes.
It would be better before 6. The problem is they see them at 6, and maybe they take a pan and say, yeah, everything's going to be crowded. Let's see them in 6 months. Let's see them in 6 months. That's kind of typical. Put them in a recall
Yeah.
thing, Ben. And, I understand where all that came from. I kind of I got to look at it from an orthodontist, how we were trained. And it doesn't fit into the academic model to see them that young, just because it doesn't fit the flow that you got to try to. You want to see the child in the orthodontic residency program from start to finish. I mean, that's just kind of the way that it's done. How the best way to do that within 3 years? Well, you got to see them later, unfortunately. So the ideal thing is if you had a program where you've got pedo and ortho really combined with each other, because a lot of the pedodontists are going to be the ones that are going to be seeing these young kids, and they need to recognize that malocclusion in the primary dentition, because they're the ones that are going to see them that early. And then if you find an orthodontist that can do it, or even if the pedodontist does it themselves, do some early expansion, to get some expansion if you're doing it for no other reason than just to make room for permanent teeth later down the road, do it for that purpose. Oh, by the way, you're probably going to improve airway and breathing and nasal function and blah, blah, blah
And
as a,
aesthetics and
as
all
a
these.
aesthetic and all that. I mean, I look at, there was a, there was a boy way back in I don't know, when I first started, I guess. And, it was typical. I did full back extraction and got them all in there. Looked great. They were real narrow looking. Okay. But then he grew up. I saw him at 20 or so years of age. And he's this big old guy. And he's got this little bitty smile. And I'm going, man, did I do that to him? I mean, I did. I
I
did.
hear this. I mean, this is something we've all, I mean, when I have orthodontists on, general dentists, we are trained with a protocol. We get out of school, we
Hmm.
we do it. I mean, why else wouldn't we? That's what we're
Yep.
trained to do.
That's what we're trained to
That's
do.
what we're trained to do. And we try to stay within the lanes, right?
Yep.
But it's the practice of medicine for a reason. I mean, it's changing, it's dynamic, but unfortunately, all of us, even in general dentistry, oh, we have zirconia abutments now. Oh, no one's doing that anymore because they all broke,
Yeah.
or
Yep.
it's a journey, and we do see patients where we're like, boy, I remember doing that. I would never do
Yep.
it right
Yep.
now.
That's how you learn.
And that's how you learn, but it's like you can't undo it sometimes.
Can't
It's
undo it.
so
Yep.
frustrating, but I will say this, having trying to have, grace, compassion for people that don't want to change their mindset. They have a paradigm that works in their practice. It is scary to change. Change is scary.
Yep.
And a lot of, especially orthodontists, general dentists wanting to do this, they're like, I would have to change how my schedule looks. I have to
Yep.
change how, and then there's opposition. And, what are people going to think in the community if I start doing these things a little differently? And I'm
Yep.
sure you faced
Yep.
opposition
Oh yeah.
in your community as well. But really, like you were saying, the whole reason of starting younger, we're not, and even Mike DeLuke and I had talked about this before. You don't have to expand everybody. That's not what we're saying.
Right. No. No.
There are kids that are doing just fine,
Yep.
from what we can see right now.
Yep.
They hit all the markers. They're growing well. They seem to be sleeping well. They're doing amazing in school. For
Yep.
whatever reason, they might be compensating well. Okay.
Right.
Which
Right.
goes into it's not always the size of the airway, right?
Right. Right.
Um, we have seen kids with tongue ties that develop beautiful arches. Like,
Yep.
how
Yep.
did how did that happen?
How that happened?
How did
You would
that
think.
happen? Some reason they compensated well, something we don't really fully know, but
Yep.
you do have to look at the child as a whole. And if you do have a child struggling to breathe and to sleep, and they may not be doing well in school, and you look at the PSQ, Pediatric Sleep
Yep.
Questionnaire, and
Yep.
you're like, man, tick, 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 they're hitting something's off.
Yep.
Whether they have apnea or not, they're not
Right.
thriving. And you look at a craniofacial hiccup.
Yep.
And we do know from Guilleminot's paper that it's not just TNA removal, especially
Right.
the non-obese child, when you have tonsils and adenoids removed, and then that 6-month honeymoon period is over, um, and things start to surge back. We see a resurgence. It's
Yep.
craniofacial issues. It's
Yeah.
fine.
Yeah.
Got to get all of that on board. Um, so what we're asking is for you to be open to to the person listening right now. Maybe you change your health history a little bit first.
Yep. Yep.
Maybe you start
Yep.
asking these questions about how does your child sleep? Do they wet the
Yep.
bed? Are they mouth?
Yep.
Maybe you start looking for the allergic shiners and
Right.
any Morgan lines and the
Yep.
uh, you look at chap lips and you watch and do they have ADD, ADHD?
Mm-hmm.
Maybe
Mm-hmm.
you start there. And then you're like, you're you kind of are high risk. And
Yep.
then you also have a craniofacial development um, hiccup that
Yep.
we need to
Yep.
get back on track. The bottom line is we need to do dentistry. We need to
Yep.
do craniofacial
Yep.
development when we see the
Yep.
malocclusion. And then if you have a side effect of improving breathing, sleep
Yep.
gets a little better, then
Yep.
then great.
Yeah. One thing you're probably familiar with, we've Steve Carstensen and Jerry Simmons are co-chairs of a committee, and I'm a member of that committee with a lot of others called the Children's Airway Screener Task Force. Steve Carstensen was the champion to go before the ADA and get this
Yes.
started, and then Jerry Simmons, as the medical doctor, is actually the chairman of this committee, which I think the first time a medical doctor has been a chairman of a dental committee. But we formed this thing called the Children's CGAS, Children's General Airway Screening Protocol, which we're trying to get validated. But it's a 5 questionnaire, and it's a simple thing. We're trying to, the PSQ is great, but it's a lot of questions.
It's a lot of
So,
questions.
so what we did is we boiled it down to 5 questions. Basically, the question, I can't remember them all, but does your child snore? Do they have restless sleep? Do they have behavioral issues? How well do they do in school? So we don't talk about ADHD, but we talk about some of the symptoms and some other things. Do they have, do they kick the covers off and stuff like that? And, so it's a 5 questionnaire that's real simple that a parent can do. Now we've got it. We're starting to get it validated. Actually, Jerry has developed this thing where it's actually online, and the parent actually fills it out online, and the information goes to the cloud, and we keep up with those statistics. Now, Kevin Boyd and I have added to that CAS committee or the CGAS to measure like intermolar width and to define some of the malocclusion things. Do they have a mandibular recession over the class 2 especially? And is the intermolar width doesn't reflect the bone, but it at least affect, what's the intermolar width, because that is reflective of, the transverse dimension of the bone too. So we're trying to put all this stuff together and trying to get that validated. We're in the process right now trying to get the funding so we can actually test that against polysonography, and even uh,
Right.
Jerry Simmons uses a sleep image ring. This is an aura ring. It doesn't do, but the sleep image ring is one that he can look at cardiopulmonary coupling and
Yes.
heart rate variability and a lot of other things
Beyond
because
the
it's
AHI, beyond.
beyond the AHI. And even Dr. Gimeno, good question bringing that up. I remember him, and he told me specifically before he died, he said, Dr. DeMent and I wish we'd never developed that because it's being used the wrong way. It's
Yeah.
being used the wrong way in insurance. It's being used the wrong way by sleep physicians. In an adult, you have 4.9 events per hour. You're considered not having sleep apnea. If you have 5.0, you are. And it's not that sensitive. It's not, you know, we artificially break those things down into mild, moderate, severe, and if everybody looks at mild and thinks, well, that's insignificant. That's like saying I had a mild heart attack or my wife's mildly pregnant.
Yeah.
it,
Yeah.
it,
Mildly
it,
pregnant.
mild does not mean insignificant. That word mild needs to be changed. They're looking at trying to maybe
And
do
it's
another.
so true. I mean, none of that even correlates to quality of life. I mean, it's all over the
No,
place.
it's
And
all over the place.
right
And
now,
here's the thing about kids, and even in the white paper by the American Association of Orthodontics did a white paper on some of this. They talked about sleep apnea in kids. Okay, that's 2 to 4% of
right.
children that actually legitimately probably have sleep apnea. It's it's not about that. It's about upper airway resistance. It's about respiratory effort related arousals. It's about the stuff before. Sleep apnea is the end result
Yeah, that's
of the
end
thing.
stage disease. If you have a
It's the
child
end.
with, yeah, it's end
Yeah.
stage.
It's all about these subtle things. And even now, Jerry Simmons, when he does polysonography on adults, he also runs an esophageal monitor down the nose. Nicole Goldfarb had this stuff where they put a pressure monitor down your esophagus at the level of the heart. So it's looking at manometry, it's looking at the flow, the pressure that's occurring at the level of the heart to pick up these upper airway resistance things. Now, insurance, Medicare, Medicaid, and all that, they don't recognize upper airway resistance as a problem. You have to have frank sleep apnea for it to consider payment and all that other stuff. But it's the upper airway resistance, which is the thing before the step before. And that's what occurs in children that we don't pick up. We can't see the forest for the trees. And like I said, it's kind of hidden because you see all these nice pearly white teeth. Oh, and then my child, they're so pretty, they got nice baby teeth. See, here's another thought that I've had in my mind. Children that have big dimples, you always think, oh, they have cute little dimples and aren't they cute? What the dimples may mean that they're maxillary recessive, that the whole maxillary bone is sitting back, and that's evolutionarily what's happened is our face has gotten smaller and our brains have gotten bigger as we have developed over time. If you look back before the Industrial Revolution, there was very little malocclusion. If you
Correct.
look back in those skulls, even just a few hundred years ago, Mariana Evans
Yep.
and Kevin Boyd have gone to the Penn Museum and looked back. I mean, I'm not talking about Neanderthals millions of years ago. We know they were fuller and everything was wide and forward. They had room for 32 teeth without a problem. We don't know about the airway, but we got to assume all that stuff's bigger. So it probably, you can look at the structural parts of the nose and say, they didn't have they didn't have crooked teeth back
Yeah.
then, really.
Well, and even when I started this journey, for the person listening that only is, I say only, but they're treating maybe adult dental sleep medicine only at this point.
Hmm. Yep.
Very needed, and I still do it. I still use mandibular advancement devices. Um, it's managing an airway. It's managing airway patency. These people have to breathe.
Yep.
You look at this adult and you think, if I could go back in a time machine and help this adult, I mean, we can even see it in the evolution of this one human from childhood to adulthood of the vaulted palate, the narrow face, the retrognathia, and you're like, oh, I mean, it's multifaceted, but if I could have at least gotten to you from a craniofacial development,
Yep.
perspective when you were younger,
Yep.
what would have changed? What would your life have been like differently?
Yep.
If we could get to
Yep.
these. Okay, we're getting closer to the end of this.
Okay.
I wanted to give you the floor for a second,
Okay.
and then I'll ask you my random questions here in a few.
Okay.
But
Okay.
for the person listening right now who may be on the fence about taking their kiddo to have an evaluation, or maybe how about we speak to the person that could be doing this kind of intervention early or screening earlier, and they're not.
Yep.
How do you speak to that person to potentially change the mindset, to potentially shift their way of thinking?
Okay.
Maybe
Yep.
I start looking younger at these.
Looking further. Yeah.
What,
Good.
how do you?
Great question. And let me tell you, there's a research project out there that was done that looked at brain function, functional MRI, brain function. They looked at two simple things, mouth breathers versus nose breathers. And they put them in a functional MRI and look at the difference, just mouth breathing versus nose breathing. And what they found was that less intellectual activity areas in the brain were lit up during mouth breathing than nose breathing. Now, mouth breathers and nose breathers, that's an integral part of orthodontics to look at.
Right.
I mean, just look at everything else, but is the child mouth breathing versus nose breathing? If they're mouth breathing, they're going to have a longer, narrower face, everything. I mean, it sets the stage. So now there's a study that proves that there are brain changes, but it also affects the heart. I mean, we're talking way beyond just pretty teeth
Yeah.
and dentistry and all that. This one day is going to be finally, we're going to figure it out. Finally, we orthodontists and pediatric dentists and dentists are going to start oh well, it's just part of our practice now because it's these these are the kind of research things that it's going to take. I mean, when I read that study, I went, my goodness, how can you ignore that? A patient that mouth breathes most of the time and they're stopped up all the time and they can't breathe through the nose, that goes into the whole thing that Karen Davidson talks about, nasal resistance. And
Yeah.
that's why we measure nasal resistance before, during, and after expansion and things like that. And here's the problem. A lot of orthodontist or dentist will come up and say, well, where's the proof? Where's the research that proves all this? Well, here's your problem. You cannot do the study. It's unethical and you can't do the study to prove it beyond a shadow of a doubt. Here's why. Because you'd have to take a major group of kids, let's say 1 million kids, divide them into two groups. Half of them you're going to watchfully wait. The other half you're going to treat early, and then you're going to see what happens to them. You can't ethically do that and withhold treatment that could have a major impact upon their life, which we think it, we can see that it does. We know it does, but you can't do the study. So then people say, well, if the evidence based is not there, that evidence based kind of you got to look beyond that. You can't just look down the evidence based straw.
Well, and
That
evidence-based medicine isn't just literature.
no,
It,
it's not.
everybody says it like as if everything is hinged on the literature.
Yeah,
Granted, when we
yeah,
see patterns and we see things in our practice, we should
yep,
investigate, and hopefully it drives literature.
yep.
To wait for the literature, you're going to be waiting a long time, and it may not, like you said, some of
There are
those.
a lot of things out there that are not like there's never been a study that shows that local anesthesia has any effect upon the extraction of wisdom teeth. Never been a randomized control sample to prove that a local or IV anesthesia has any effect upon the extraction of wisdom teeth. But who's going to volunteer and not get anesthetized to get their wisdom teeth out? It ain't going to happen. You know, it has no effect upon really the taking out wisdom teeth. It doesn't have any. It just it puts the patient in a situation. So it's like there's certain things that just are.
Yeah. There's
They
certain
just
things that just logically start to make
they
sense.
just logically are. And I can't. I don't practice anecdotally. I try to practice things that I have done that seem. I mean, but a lot of these things you can't wait. You're not doing the patient a service trying to think, well, since there's no hard data out there, that I'm not going to believe any of this stuff. I
Well,
mean,
and here's the
that's
bottom line,
crazy.
you know, do the dentistry, do the orthodontics, do the orthopedics.
Yep.
Uh, when you see the hiccup, don't wait, just do
Don't
it.
wait.
Get the kid
At
back
least
on.
send them to somebody else if you don't want to do it.
And if you don't want to do it, send it to somebody that will. So,
Yep.
thank you for being on
Yep.
today. I got to ask you these
Okay.
enlightening questions. I got to put my readers on.
Okay.
Okay, here we go, Bill. Um, if you had to eat one food or one dish the rest of your life, you could pick one food or one dish that you had to eat the rest of your life, what would it be?
There's a chicken dish that I love. It's called Heavenly Chicken. You it's chicken breast, but you have mushroom soup. You line the pan with dried beef,
Ooh.
and you put a layer of chicken with mushroom soup, and then you line the whole top of it with dried beef again, and you cook it for, I don't know, 350 degrees for whatever. It's better the next day. It's better if you cook it and
Everything's
let it
better the next
sit.
day. It just kind of takes up
It
all.
is my dream thing. My wife doesn't cook much anymore, so I don't get to have it. But it's one of the things my mother made a long time ago. So it's kind of a thing called Heavenly Chicken.
It sounds good,
It's
especially
really simple to do. You just
I'm kind
line
of
the
taking note right now. I'm like,
Yeah, I know it. Try it and see.
I'll probably
Yeah.
reach out to you for the recipe later.
Oh, you put bacon on top too. You have to put
Oh,
bacon.
shoot. Well, if you put bacon on it,
It always makes it better. That's
Yeah.
right.
Okay, so heavenly chicken. Here's your second question. If you have a
Okay.
chance to explore the ocean or space, which would you?
Ooh, definitely space. When this whole thing, because I grew up I was born in the late 40s, but I grew up during the space race in the 60s and all that kind of stuff. And one of the things as a teenager, it was like, I want to be an astronaut. I mean, back then, that was the thing that everybody wanted to be. I mean, if I could hop on Elon Musk's rocket or something like that and go up in space, I'd do that in a second. I just think I don't know. There's so much, I don't know, all about that.
Yes.
I mean, when you look at, and I look at some of these Facebook pages and there's things about here's the Milky Way, here's where we are, and the vastness of all this stuff. I mean, it's mind-boggling. But
It is
it
my
would be I would love to if I could have a chance to go up in space, I'd do it in a second.
love it. Okay. If you had one superpower, if you could have one superpower, what would it be?
Gosh, that's interesting. Um, I don't know, kind of being invisible, maybe
Yeah,
being
that
invisible, because then you could kind of sneak in places and and
I want to know what's happening, but I've thought about that too. It,
yeah, just because you could go into in the White House or something. I mean, you could kind of go in and be in secret meetings or something and hear the real stories on things, or just kind of be able to go behind the scenes in certain things and know the real,
and know the
you
real
know,
scoop. So
real
if Bill
scoop.
Harrell wasn't an orthodontist, he'd be a spy with invisible.
Bye. Yeah, yeah.
Okay.
That'd
Well,
be good.
Bill, thank you
Yeah.
for coming on
Thank
today.
you,
And
Stacy.
I'm
Appreciate
looking,
that.
absolutely, I'm looking forward to your book launch and for
Thank
the
you.
person listening right now. Oh, I wanted to say this too.
Okay.
Shoot, I forgot to say it earlier, but if people want to uh, have you come to their communities and speak, I'm
Yep.
going to put your email address in the link, but your email address is DrHarrell, Dr. Harrell, at AOL.com.
Yep.
You can come to the community, you can do study clubs and help educate. Also, um, the Airway Breathing Academy. I don't want to stay long on this. Uh, just to not take so much of your time, but you and Dr.
Okay.
David McIntosh, he is the ENT out of Australia. He's amazing. You guys are going to have an event. You got a whole program coming, but you're going to have an event in October in Las Vegas. And if
Mhm.
people, right now, you don't have a link to register for that,
Right. Right.
but if people want to, um, then they could email you and you can give them that information on
Yep.
that.
Yep. If you're just putting the subject line like Las Vegas course or something like that, so I can do it. But I'll be glad to keep a list of that, and then I can let everybody know. It's going to be October the 10th is what it's scheduled for right now at a really interesting venue that is geared toward uh, helping experts get their word out.
Yeah.
And
That'll
just to
be exciting.
give you a little idea, they work with Tony Robbins, so they're for real.
Well, it sounds like it's going to be a lively event, so
Yeah,
that'll.
I think it is. Yeah. And
Well,
we got a lot of we're gonna do a lot of Zoom meetings, and we got a lot of content that's already been recorded that are going to be available through this academy.
I'm
And we'll
excited.
have people, and we'll have people on like you and some other people in some different areas, because we're all kind of working together. We all
Yes,
got to
we
work
are.
together in this thing,
We have to work together, and
because we all touch different groups.
we do. We do. And
We
it
really
takes
do.
everybody talking about this. It takes
It does.
everybody working
Absolutely.
together, talking about this to help as many families and as many kiddos as we can.
Yep.
Thanks again, Bill,
Okay.
for being
Thank
here.
you.
All right.
Good deal.
And then
Thank you,
I'll see
Stacy.
everybody next time.
Yep. Good deal. Bye bye.
Bye-bye.